Bonjour, Dr.
Bonjour,
Lacotte.
Rebecca.
So nice to be here, and thank you for having me here at Massy. I really appreciate it. And so I'd just like to start by saying thank you for all you're doing and the collaboration and the partnership you have with Medtronic across all of the portfolio, and certainly also your enrollments in the Real Pulse Registry, as we know that data for PFA is going to become critically important in the real world as we go forward. So what I'd like to ask you first is, how do you think about our whole portfolio? We have Cryo, we have Pulse Select, we have Affera, all things now across the entire spectrum of what a company needs to be a full EP portfolio. But how do you think about it, and how do you think about partnering with us?
It's very impressive. Your portfolio is very impressive. Medtronic is back in the field of EP with nice technologies, nice single-shot technologies, corresponding with, let's say, 90% of our needs. For conventional PVI interventions with Cryo and with new PFA, Pulse Select catheter, which is the everyday technology we use in the vast majority of our patients. 30, 40 minutes skin to skin, same day discharge, 90% of patients feeling well or doing well after 1 year. And on the other hand, we have game changer with Affera. Game changer because after 25 years of practicing EP every day, it's the first time that when I press a paddle using the Sphere 9 catheter, I'm sure that I'm curing the patient for good. Because with the old thermal energies, the crucial issue is to know if we are delivering enough energy to burn the tissue, with 1/3 of patients recurring on the same place, veins or lines.
Yeah, thank you for that. And, it's been a journey for us to, bring our own pulse field ablation technology to market, as well as through the acquisition of Affera. And we really wanted to make sure when we brought a mapping system to market that it was a system that would be leveraged immediately and have the tools and the opportunity for you to use it, not be seen as a first generation technology. And I think we've done that. But my question for you is, when you're thinking about our portfolio across the board, how do you decide which patients get what?
Patient first, so it's always safety and efficacy first. But there is no major difference if you look at randomized studies. So our position is after safety and efficacy, what's the cath lab efficiency changing with new technologies? Do we save time? Do we save energy? Less mental stress for the team, the patient, the physicians, and the paramedics. So that's why we move more and more to single shot technologies, no maps, just a few minutes of X-rays, with very reproducible duration of interventions and outcomes, being able to cure more and more patients with limited number of days or slots to ablate patients every day. In terms of technology selections, there is no major difference. It could be price and cost, comparing old and new technologies. It could be some very limited patient's criteria, some patient being allergic to contrast medias. And regarding lab efficiency, there is a crucial point, which is anesthesia. It's hard today to perform PFA without general anesthesia. And we are lucky, and our patients are lucky, because we perform all our interventions with general anesthesia. It takes 10, 20 seconds more compared with sedations, but we are convinced that it's better for our patient.
Great. So when you wake up in the morning, do you say, which of those technologies would you want to use?
When I wake up in the morning, I hope that all the patients will be cured with no adverse events, that I will be back home as soon as possible. And no, moving to single shot makes me sure and convinced that we are giving the best for our patient in a limited number of hours in the lab, and that nurses patients and physicians will be returned home before 6 or 7 p.m. because we are limited in terms of interventions every day. We cannot perform same-day discharge patients after 1, 2 p.m. So it means that in the afternoon, it's always challenging patients, complex ablations. And in the morning, it's conventional PVI, it's simple PVI procedures. And that's the period of time when we must have a very efficient lab in the morning between 7, 8, and 1, 2 p.m., being able to perform 4, 5, 6 PVI cases.
Great. And so one of the themes that comes through with you very clearly in everything you talk about is making sure that your team is satisfied with how the outcomes are going to look for patients, how patient outcomes are at the top priority of every single thing that you do, regardless of the technology. And so what are a few things that you think about when it comes to managing your team and managing the patients for the longer term, not just on the day of the procedure, but as you go forward?
Yeah, Rebecca, we were wrong in the beginning, hoping that we will be able to cure every AF patient like Wolff Parkinson White patient or Flutter patient, because it's a chronic disease with comorbidities. And it means that we have to manage patients during years. Well, it's a chronic disease. And I'm convinced that the outcome after 1 year depends on what you do before the ablation, what you do during the ablation strategy, catheter selection, and what you do after. Is really defining the outcomes after 1 year. But we must collect this outcome after 1 year. And it takes a lot of time and energy. We decided 6 months before to have a nurse dedicated for that, collecting PROMs and PREMs, patients-related outcomes and experience, to help us understanding why this patient is happy, unhappy, recurring, and how to get the best from the technology you're providing today.
One of the things I'm pretty passionate about is burden and really understanding not just 30 seconds of AFib, but how do we do a better job of reducing the burden for patients and even understanding that, because a patient may come back with 30 seconds of AFib, but they may feel great.
Yeah.
And so maybe elaborate a little bit on your thoughts around burden and what we should be doing in that space.
We must change this criteria. Having more than 30 seconds of AF on a Holter means nothing in my experience.
Mm-hmm.
In our lab, we have less than 10% of patients coming for a second ablation 2-3 years after the first procedure, less than 10%. If you look at Holters, there are 30% of patients recurring mainly with an asymptomatic manner. And we know that for 20 years or 30 years, that patients are recurring with asymptomatic small recurrences. So burden is certainly the best criteria, and quality of life, and both are perfectly correlated. But the issue is how to collect AF burden. Is it subcutaneous Holter? Is it watches, smart watches? But we must change this criteria.
One of the things that we could consider on our side is how do we use AI with Affera now that we have a mapping platform and the capability to gather the information and data that you described, combine it with the procedure, and then follow how patients are managed ongoing. Some of that may be able to be done with Get Ready or some of the tools that we have as well, but integrated with Affera I think would be a good place for us to start.
Yeah, it's amazing to imagine how many informations are lost every day because our 3D mapping systems are not connected and not collecting data. Every week in France, almost 1,000 AF ablations are performed. Maybe 1 or 2 patients are included in a clinical study. So for 20 years now, there are 1,000 patients lost and information lost. So you must help us collecting this data. It takes time, and we must decide what are the endpoints. There are beautiful things that we can do together if we can collect these data.
I agree, absolutely. I'd like to circle back a little bit to Pulse Select, and one of the things that you mentioned about patient discharge and same-day discharge, one of the things that we have with the Pulse Select catheter is a 10 French sheath, which I think could help with, ensuring that patients have a good experience. And so maybe you can describe your experience with Pulse Select a bit.
Yes, this size of sheath is crucial for patient experience in terms of bleeding, in terms of discharge, in terms of adverse events, even in terms of headache. The nurse, which is working with us for 6 months now, told us, that every time you perform PVI ablation with a large sheath, there are headaches during 2, 3, 4, 5 days, requiring painkillers. On the other side, with smaller sheath, the patient has a better experience. So as safety and efficacy is not different, it's not really different for patients. In our lab, it's really important to hear that and to move or to change our habits if it's better for the patient. Single shot, you can understand single shot as single puncture, single shot, single puncture, single transeptal puncture. Today, we're performing PVI with Pulse Select with no other catheters. Just Pulse Select, one puncture in the vein, one transeptal puncture, a few burns in every vein with just one catheter. And it makes huge differences at the end of the day.
That's impressive, and patients are probably happy as well. Kind of continuing that thread with Affera, it has the ability to map ablate and ablate with 2 different energies. How are you utilizing that 2 energy source with Affera?
We're mainly using PFA, Rebecca. It's so fast, so reliable, so impressive. Mainly PFA.
Just drop the mic on that. All right. All right, very good. So do you have any questions for me?
What's your vision regarding single shot? Will it be connected to 3D with cable, maps?
Yeah.
Maybe it's better for navigation and understanding, but it takes time to connect maps. Or will it be very simple ablation with just X-rays or CT fusion, for example?
Yeah, so I think what we're trying to build is an experience that allows physicians to use these technologies in any way that you see fit. And so certainly for Pulse Select, it's available on any of the mapping systems. We'll also have it integrated with the Affera system coming sometime next year. And so we believe it's important for physicians like you to have the same experience across all of our technologies. So we will build an impedance-based system inside Affera so that we can manage both Pulse Select and cryo on that system.
So the best is to leave it open.
I believe the best is to leave it open. Absolutely. It's up to you if you want to use fluoro, you want to use, mapping and navigation, ICE, whatever it might be.
Yeah, leave it open and push datas. Collect datas.
Agree. Thank you so much. I really appreciate the time and the opportunity to be here with you, and thanks for your hospitality.
Merci, Rebecca.
Merci.